All right, we'll go ahead and just get started with introductions. Good morning. It's cold in the plains. That unexpected little snowstorm that comes sometimes in October. I guess this is the third year in a row we've had this, so we shouldn't be surprised, but it always does surprise us in October, it seems like. Today is October 27th. My youngest grandson is 1 year old today, so that's fun. So it gives us something to look forward to. Thank you for attending. We really appreciate you coming back and attending with us and learning more about telemedicine with this ECHO format. And we want to continue this, but I think we're going to go and start doing once a month now. Because of the COVID, still hammering us, we don't want to end these telemedicines, but we do realize that a couple of times a month or even every week was just too much for a lot of people. So we appreciate that. So what we would like for you to do, because we are in that planning phase for didactics, is today you get to put in the chat your ideas of what it is that you want to hear about. We want this to be helpful to you. And so we would really love to have your ideas and things that would speak to you. So if you wouldn't mind kind of jotting down a few ideas and throwing those in the chat, that would be most helpful to us. And I'll announce that again towards the end of the ECHO so that others that are having trouble getting on today can join in with that as well. So we would appreciate that. This ECHO, of course, is a joint effort between the Heartland Telehealth Resource Center and the Missouri Telehealth Network. And so we're offering this ECHO to people in 3 states, Missouri, Oklahoma, and Kansas, so that we can address topics about telemedicine. I'm Janine Gracie, project coordinator for the HTRC, and I have the honor to moderate these sessions. But before we get started, let's introduce the hub team. Let's start with Rachel.
Good morning, everybody. Rachel Mutro from the Missouri Telehealth Network, Show Me ECHO program, and the Heartland Telehealth Resource Center. Welcome.
Thank you, Rachel. Evelyn.
Good morning. I'm a psychologist. I'm Evelyn Nelson. I'm a psychologist at KU Med Center, and then the PI for the Heartland Telehealth Resource Center. Great to see everybody this morning.
Thank you, Evelyn. Robert.
Excuse me, I haven't talked yet this morning. I'm Robert Stiles. I work with K School Medicine and with the Heartland Telehealth Resource Center.
Thanks, Robert. I think we all experience that from home. Sometimes it's the first time we speak to anybody. So thank you for that. All right, and Tim.
Good morning, Tim Davis, Telehealth Manager at Oklahoma State University Center for Health Sciences. I also work with Telehealth Alliance of Oklahoma and HTRC.
Thanks so much, Tim. Great. Okay. When we have this small group, we usually go ahead and have everybody introduce themselves, but because we used some of the time to wait for people to be able to log on, since we're having a little trouble with that, we'll forego those and just make sure that you introduce yourself in the chat. And also remember to put ideas for upcoming telemedicine echoes in the chat as well. So thank you. All right. Before we get started, make sure that you right-click on your picture, hit rename, and put the state that you are from. That is helpful for us when we go to answer questions and identify differences in states. That's what's so unique about a tri-state echo. We want you to be able to ask questions, but please keep yourself on mute until the question and answer period of echo. And that way we can address those and keep the noise down for the speaker. Now, I just want to remind you that these presentations and associated documents are in Box If you have trouble accessing that, just let Cece or I know about that, and we will get you in there. But all of the ECHO documents are in there from past echoes, and so it's a plethora of information on telemedicine. So please go in there and take a look at that if you haven't done that already. We will cases, we haven't had a lot of cases in this telemedicine. So I want you to think about that. If you're giving an idea for a topic, and you know of, a problem or a barrier, or maybe somehow a success of how you addressed that, please consider doing a case study for the ECHO so that we can all learn from each other. I think, that is the value of ECHO, is when we're all able to say, hey, that's a great idea, or I had that problem and this is how I solved it. So please consider doing a case study when you are thinking about some of these topics that you would like to see addressed as we move forward. And we would like to get some didactics down for the rest of 2020 as well as going into 2021, because we know that telemedicine is still going strong in this era of COVID. So please, let's do that. So now let me introduce Richelle Marting. She is a clinical assistant professor at the University of Kansas Medical Center. She teaches healthcare policy and governance, legal aspects of health information management, and health reimbursement. When we get caught in a tough bind, in terms of reimbursement, Richelle usually is able to help us work that out. Her research focuses on privacy standards for information collected by healthcare providers and the evolving payment structures through which healthcare organizations are paid by government and other third-party payers. This session is going to discuss how privacy laws are impacting the delivery of telehealth and payment for those services. And she will be discussing HIPAA rules and current topics affecting privacy and security in telehealth. So Richelle, I'm just going to let you take it away.
All right. Thank you, Janine. While I'm pulling my screen up here, hopefully can share the screen hopefully everybody can see that now. A couple other thoughts as Janine was doing the introduction. I've spent 10 years of my career focusing on the legal aspects of health information management. So coding, billing, reimbursement, the topics that I've talked to this group about before have always been one of my key focuses, with HIPAA and healthcare privacy being right up there, a very, very close second. And I actually just spent just shy of a year serving as the interim privacy officer for St. Luke's Health System here in the Kansas City area when their former privacy officer retired. Got some fantastic experience there, not the least of which was the middle of COVID earlier this year, January, February, March, April. As a privacy officer in a large health system, got to see firsthand, all of the different types of facilities that health system has, and the very rapid, within 7 to 10 days time, rollout of telemedicine in all of these areas that had not had telemedicine before, and our privacy and compliance office having to vet those things very, very, very quickly, as well as trying to keep track of, as you know, the almost daily, or sometimes it felt like multiple times a day, changes and information that was coming out from so many different sources on rules, requirements, waivers, and things that were happening. I'm also really active in the American Health Information Management Association and their state and local chapters, so the Kansas and Missouri chapter and the Kansas City HIM Association. And I've written the legal manual for HIM for Kansas, Missouri, and Nebraska. A huge chunk of that manual are topics relating to privacy and security of health information, which now need to be updated with some of the waivers and the things that we're going to talk about this morning. So with that, let me jump in here. to our presentation. And I wanted to start out first with a list of resources for you. And so I've sent this link so you can pull this up later. I won't go through all of these, but these are some resources and some tools I'm going to be referring to in the next few minutes here. The OCR HIPAA audit protocols. And I'll just flip my screen here. Hopefully you can still see the website that I've got pulled up. That link's going to take you to a page directly on the Federal Office for Civil Rights website. And the audit protocols are going to go into extensive detail on some of the topics that I'm going to mention at a fairly high level. If you look over here at my scroll bar and see how tiny it is, these are all the things that OCR would be looking for in very specific detail if they were to come and audit an organization's HIPAA compliance. They list the rules and then they list exactly what documents and what questions they would ask as part of their audit. So I think it's a very helpful tool if you're creating some kind of internal audit and compliance program or monitoring process. That's a great tool to take a look at. I'm also listing the website where we have the Federal Department of Health and Human Services HIPAA waivers during COVID. So during the time that we have the public health emergency that was declared by the Secretary of Health and Human Services, there are waivers of certain, let me say this a little bit more precisely. There are waivers of enforcement of certain HIPAA provisions. The provisions are still there and in effect, but the federal agency has said they will not enforce them or impose penalties for certain non-compliance. I'll pull up in just a minute a guide that I've created on my own, a business and associate analysis guide that kind of walks through the decision tree to decide if a vendor that you're working with is or is not a business associate under HIPAA, that requires that you have certain contractual protections in place before you are allowed to create, receive, maintain, transmit, exchange, give access to protected health information with that vendor. I'm going to mention the Office for Civil Rights has telehealth waivers that we'll take a look at and talk about briefly. The most recent Department of Health and Human Services at the federal level renewal of the public health emergency, and then some of the other statutes and waiver references that I'm going to be talking about. All right, so let me just briefly go through the status of the public health emergency. Well, let me pull that back up. We need this. Why is this so small? Why is that so large? There we go. We'll zoom out just a little bit there. All right, so we have at the federal level 2 emergency declarations. There was the President's National Emergency, but the key one that that really applies to the waivers and things we're talking about today is the Federal Department of Health and Human Services Public Health Emergency. You'll see that abbreviated PHE in a lot of the references and tools. So that was initially way back in January. It's been renewed a couple of times. So now it's been renewed for 90 days into, whoops, that's 2021. I'll make that correction at the end of the presentation, but through January 21st, 2021. Now that's important because we right now have a proposed rule that's hanging out there. I expect we'll get a final rule late November. It may be into December. I expect that it's going to come fairly late this year for the physician fee schedule with Medicare that is going to solidify some of the temporary telemedicine changes that we've seen during COVID and make some of those permanent changes. Some of them will continue to be temporary through the end of the calendar year when the public health emergency ends. So fingers crossed, let's say the COVID public health emergency ends sometime in 2021, or even January 21st, 2021. Well, these temporary rules, if they are finalized, would actually allow telemedicine to be delivered as proposed in this rule all the way through December 31st, 2021 for Medicare, and likely for several other payers as well. So I think that's helpful and important. We talked last time that I was with this group about some of the things that these waivers did in terms of telemedicine, expanding where they could be provided, where the patient's located, and so on. adding services to the list of telehealth services, and the proposed rule for the physician fee schedule that's out there right now would make some of those telehealth services permanent that were not telehealth services prior to COVID, and creating a whole new category that are temporary telehealth services that will continue to be covered through the end of the calendar year in which the federal public health emergency ends. There have also been some waivers of HIPAA requirements. So I have to be careful the way I say this. The Federal Department of Health and Human Services and Office for Civil Rights have waived their discretion to enforce certain provisions of HIPAA. And I'm careful to say that because the rules are still there. They are still in effect. But right now, while the public health emergency, the federal public health emergency is in place, the Office for Civil Rights won't pursue monetary penalties. But one really important piece of that is it's not HIPAA in its entirety. There was a lot of misinformation when those waivers of enforcement were initially released that we're not going to get penalized for noncompliance with HIPAA. Period. And that's not true. There are only very specific and select provisions of HIPAA that are a part of that. So you can't freely share patient information without worrying about enforcement. And it's also important, I'll emphasize several times in the next few minutes, that those are only enforcement waivers from the Federal Department of Health and Human Services. We still have state privacy laws that often reference or mirror HIPAA. So there can still be state level enforcement. There's still the Attorney General. There's still private causes of action. So while it is helpful in some ways, it is not a blanket protection for any and all HIPAA violations, certainly. Okay, I do not know why this is coming out so small. Let me zoom in here. All right, so HIPAA and telehealth. Let me go through a couple of, at a very high level, key provisions of HIPAA that come into play when we are introducing, rolling out, implementing, and delivering telehealth services. Vendor selection is a very important one. In the implementation process, as if you are a covered entity, you know that we have to give patients a notice of privacy practices. And there's some other rules with notice of privacy practices, such as posting that on your website in a clear and prominent location. That's generally considered to be a link on your homepage, but what the Office of Civil Rights has said in presentations I've watched, if they search your website and they can't find it quickly, like within the first one or two links, that's not a clear and prominent location. So that notice of privacy practices document that you are supposed to give all patients on or before the first service or first visit must be on your website. And when that first visit is via telehealth, that's something that's a little bit new, because typically we would have an established provider-patient relationship with these individuals. We would have already given them a notice of privacy practices during their first face-to-face visit in the office or brick and mortar setting before having this telehealth visit. Now we're having a virtual encounter, potentially as our very first encounter with the patient, and we still have this requirement to deliver a notice of privacy practices on or before that visit. That particular requirement is something that OCR has said they will waive enforcement of right now during the public health emergency. But I would urge you all, now that we're out of that initial kind of acute phase of the emergency, to really think about how you can implement that for a long-term solution and get the notice of privacy practices to the patient on or before that first visit. And then in addition to that, we also have to receive, and in the privacy rule, it says we have to get written acknowledgement of that individual's receipt of the notice of privacy practices on or before the first visit. There are a few exceptions for emergencies, but by and large, that's the rule. So we also have to think about how we can accomplish that when we're doing telemedicine services. Let me come up to vendor selection. With vendor selection, one of the first things we have to think about is whether the vendor that we want to use meets the definition of a business associate. And I'm going to share a different document here. Go. Hopefully you can see a Word document coming up. This is kind of a decision tree guide that I had come up with as as we were better developing our processes in the privacy office of St. Luke's Health System. And so I was putting together kind of a decision tree for myself to help us standardize when we do and do not get business associate agreements. And I'd be happy to share this as a reference tool. It just walks through a series of questions to help you decide whether you need a business associate agreement with that vendor or not, because not all vendors we work with in healthcare are business associates. And when we do get a business associate agreement with a vendor, it puts some additional obligations on both parties. As a covered entity, we then need to monitor our business associates' activity and compliance with our contract, make sure they're following all of the rules for accessing and using protected health information that we have in those documents. So that's the first step, trying to figure out if the vendor that we're working with even meets the definition of a business associate under HIPAA. Selecting a platform, and that can be very important. There are some waivers I'm going to talk about in just a minute for certain platforms and types of services during the public health emergency. Encryption is a really important piece of the platform selection. How are we going to encrypt those communications as they're being delivered so that we can avoid or reduce the risk as much as possible of unauthorized access? Will we be recording the sessions? If you record those sessions that are done via telehealth, where are those recordings being stored? And under your organization's policies, do those recorded videos then become a part of the medical record and the designated record set for that patient? If so, how do you make it a part of the designated record set? Because if it is part of your medical record, patients have a right to access that. So when I send a medical records request for my visits in 2021, I would then, the provider would have to give me access to the video itself, if that's part of the encompassed in my request. Let's see, access to the platform, right? So we need some overarching concepts in HIPAA are that access to protected health information should be the minimum necessary. So only those people who need access to the platform where we will be delivering telehealth should have access. Every user should have their own account, their own username and password. We should be able to have audit logs to see who's accessing the system. And this is particularly important if recording is going to be a feature of the telehealth sessions, because then if we haven't implemented these safeguards and we only have one user account for like the whole system, I could then log in and access recordings of visits and sessions that I have had nothing to do with and no need to access. Termination of that access. If you have kind of an access onboarding checklist and termination checklist, this is another place, another account that you would need to make sure gets terminated when an individual within your organization leaves. Because Zoom and Skype and all of these platforms are so web-based, it would be very easy for someone to leave your organization and continue to have their username and password within those accounts and then have access to information after they've left. There are several examples of civil monetary penalties against organizations that did not terminate an employee's access, who then later, after leaving the organization, improperly accessed information and did some bad things with it. And then notification of events. If I'm going to pick on Zoom, since it's the platform we're using here, and this is not an issue that's limited to Zoom, but if say Zoom were to have a major issue with its servers, or a ransomware, other security event where your session's information might be stored, how will that vendor notify you of those events because you have some mutual obligations to investigate and potentially report if there's been a breach of information. I've touched on record maintenance, but with record maintenance, we have policies and procedures in place that define our designated record set. That is the subset of medical records that a patient has the right to access when they're requesting their medical records. And it has a definition, anything used in whole or in part to make decisions about your patient. So if you have chosen to record those sessions, it's almost like a video transcription of a written progress note for a session. So it very well could fall under the definition of designated record set if you're choosing to record those sessions and keep those recordings. If that's the case, you've got some additional work to do to figure out how to make that information identifiable in the medical record and accessible in the medical record to those who may need it. Who's present for this session can be important. That can have billing implications, and it can have some HIPAA implications. From a HIPAA perspective, just like a face-to-face visit, you can have individuals other than the patient present for the visit, right? If they want to bring their spouse, their parent, their child into the session, from a privacy perspective, it works the exact same way as an in-person visit. And the rule under HIPAA that lets us do that says that when the patient is present with another individual, we can share protected health information as long as the patient doesn't object. So it's almost like implying consent to talk to those other individuals or talk to the patient in front of those individuals. But if something particularly sensitive comes up, maybe you're with a teenager who's got mom or dad in the room or other caregiver, and you want to talk about, sexual behavior, alcohol, drug abuse, things that could be sensitive topics, just like you would in a face-to-face visit, you might ask mom and dad or caregiver if you can have some privacy to talk to the patient and otherwise get the patient's consent to continue with that discussion. So there's always professional judgment, but from a HIPAA perspective, those conversations are permitted. Security risk assessment is another really big feature of the HIPAA security rules that are going to come into play with telemedicine. With the security risk assessment requirement, it says that you have to inventory all the places where your patient information is created, received, maintained, or transmitted. So that includes your business associates, and you need to know who your business associates are. You have to understand the safeguards that they're using with your protected health information. Are they selling your data, your information? Are they accessing information about their sessions? That's all part of your organization's security risk assessment and understanding those threats, those vulnerabilities to your information. I've got in bold right here in the center, information blocking. A set of privacy rules, not really privacy, I'd call them access rules that are going into effect here in just a few days. And these new information blocking rules, we could have a whole day workshop on HIPAA and information blocking and how they do and do not work together. But these new rules really take a different approach to health information, because with HIPAA, we start with a default of minimum necessary. You use, create, receive, access the minimum information that is needed for a particular task or function. Yet information blocking takes a different perspective in terms of sharing information with the patient themselves or with other providers. It's trying to avoid barriers, and the default with information blocking rules is you give it to the patient, you give the information to other healthcare providers unless one of 8 exceptions applies. So right now, organizations are having to really go through their written HIPAA policies and processes and making sure those are aligned with information blocking rules in terms of limiting disclosures to patients and to others. So we're still following HIPAA, yet we're not creating barriers to access to information under information blocking rules. So as I've mentioned and emphasized, this is really important. HIPAA is still in effect during COVID and during the public health emergency. but the Federal Department of Health and Human Services has waived its discretionary authority to impose penalties for certain provisions of HIPAA. So those are obtaining an agreement with the patient to speak with family and friends about protected health information. If you have a slip up and you don't get the patient's verbal or implied consent to do that right now, OCR would not impose penalties on your organization. If you're a facility that has a directory, hospital directory that shows the patient's location, their general condition, and the patient opts out of participation in that directory, and you slip up and you give information from the directory, right now, the OCR says they would not impose any penalties for that. Distributing the notice of privacy practices. So let me put an asterisk on this. While the Federal Department of Health and Human Services would not impose penalties if you do not successfully get your notice of privacy practices to a patient on or before the first visit, just particularly challenging in telehealth, or you fail to get written acknowledgement that the patient received it, they would not impose enforcement or monetary penalties right now. However, I strongly encourage organizations that are creating telemedicine as a longer term solution to get this process in place. At some point, the public health emergency ends, and you're going to have patients in your system that you're continuing to visit with via telemedicine. And you will need that written acknowledgement at some point in time. And if you failed to do it during the first visit, and that's your normal process for in-person visits, you are likely to neglect to get that documentation down the road when the enforcement is back on. And so I highly encourage you to think through that process and make sure you're complying with that provision now. Honoring requests for restrictions if the patient doesn't want their information to go to certain people or certain places, and you've agreed to those restrictions and you slip up during the public health emergency, there won't be enforcement from the federal agencies on that now. And honoring requests for confidential communications, which says the patient has the right to ask that you communicate with them in certain places or in certain ways, by phone, by text, by email, by fax, at a certain address, whatever that is. So those are the limited waivers on enforcement of HIPAA provisions during the public health emergency. And I want to emphasize again, this is only from the Federal Office for Civil Rights, and where that is the primary place that your penalties and consequences may come from. State attorney generals can still enforce HIPAA also. You could still have private causes of action, not for HIPAA violations, but private causes of action for invasion of privacy under state law, or in violation of state privacy laws outside of the HIPAA, the federal HIPAA rules and regulations. All right, these are just all out of whack from where I had them. Let me quickly go through a couple of the telehealth waivers from the Federal Office of Civil Rights. So Office for Civil Rights not only waived its right to enforce some of the HIPAA provisions, but it has some waivers specifically for telehealth services that are important to us. Normally, the vendor and the platform that we're using for telehealth has to be pretty solid, secure, and locked down. We've got to have encryption. We've got to have all of the normal security safeguards that you would have on your electronic medical record system. Some of those requirements are relaxed right now during the public health emergency with respect to telehealth. And the Office for Civil Rights says that we can use any non-public facing remote communication product that's available to communicate with patients. I'll go through what's public facing and what's non-public facing in just a minute. That non-enforcement discretion applies to telehealth provided for any reason. So your telehealth visit doesn't have to be related to COVID or a COVID symptom or a COVID condition. Providers are encouraged but not required to notify patients that the third-party application that you're using could have privacy risks because you may be using a platform or a product that is maybe less secure than you would use in other circumstances. The platform that you use should enable you as a provider should enable all available encryption, privacy, and security safeguards that are available through your telehealth platform to make it as secure as possible. And OCR really wants you to use vendors that will enter into business associate agreements for telehealth services. So in this Office for Civil Rights guidance, and I've got a link to this page, it's on the resources link from the beginning of the session. Some that OCR specifically mentions, although are not endorsed expressly. So if you choose one of these, it's not like a safe harbor for you, but they mention that Apple or FaceTime or Facebook Messenger video chat, Google Hangouts, Zoom, Skype, WebEx, those are examples of platforms that are non-public facing because you can have a private communication one-on-one with that individual. And again, they're not endorsing these. These are just examples that are not public facing. Public facing platforms, which would not be okay to use for telehealth. I think it goes without saying, but OCR mentioned it. So there must be folks out there thinking that it could be an option. Facebook Live, where it's like broadcast on somebody's Facebook, not okay. Twitch, I don't know what that is. TikTok, similar video communications that will, Snapchat, that would broadcast the video to others other than just you and the person that you're having that session with. In that same webpage, OCR lists vendors that have represented that they will enter into business associate agreements. So let me put an asterisk on this. Just because the vendor will enter into a business associate agreement doesn't make them a good and secure vendor. Not all business associate agreements are made the same. And it's also very important when you're choosing a vendor, not all of those vendors' platforms are quote unquote HIPAA compliant or designed to meet the security standards of HIPAA. So take say Skype, for example. There is a Skype platform or product that is designed to meet HIPAA security standards. And if you purchase that platform, it would come with a business associate agreement. But if you get the free version of Skype, you're not getting the business associate protections and the security safeguards that are part of the more expensive healthcare compliant product. So look for that when you're choosing your vendors and services. Also know that while these vendors will enter or have represented that they will enter into business associate agreements, many of them are take it or leave it documents, and they are not provider friendly. For example, they may have limitations on liability where your business associate could really screw something up with your health information and take no financial responsibility for it, and they will not make revisions to those documents. So that's something to keep in mind too when you're looking at the business associate agreements. So just really briefly, and I am so sorry, this formatting is looking much different than it was on my end. Wanted to go through Kansas, Missouri, Oklahoma, and to save time and make sure you've got time to answer questions, I'll just generally state all of the emergency statuses are still in effect, and the executive orders relevant to the delivery of telemedicine have been continued in those states. So in Kansas, for example, our privacy laws align with the federal HIPAA laws. And that change happened, gosh, 5, 6, maybe it's been closer to 10 years ago, relatively recently, a change that I can remember. But our state attorney general can still enforce HIPAA violations and violations of our state privacy laws. Board of Healing Arts can investigate and impose disciplinary action for violations of those as well. Now in Missouri, the state emergency declaration has been extended through the end of the year. and gives the State Department of Health and Human Services the authority to issue waivers. There are some telemedicine waivers, like licensing rules for healthcare providers, but there aren't any HIPAA specific waivers at the state level in any of these states relevant to privacy rules outside of our normal telehealth waivers. Oklahoma, your emergency waiver is also still in effect. No privacy specific waivers as part of that emergency. So like everything else, I think I've gone over my 15 minutes, but I will stop there and open it up for questions.
Absolutely. Thank you so much, Richelle. That is, you packed a lot of information in a short amount of time, and we certainly appreciate that. So do we have any questions from the group that somebody would like to ask? So don't forget to unmute and ask your question.
Janine, there was a question in chat from Suzanne Operman.
Okay.
Suzanne, are you with us?
I am. My question was, I had a client who a new client who wouldn't meet with me because she had found negative information on the EHR telehealth company that I was using. And my question is there a place for us non-IT people to go to see what is reliable and what's not? Because from the presentation you gave, I feel rather lost trying to find my information.
Yes. Okay. So kind of a two-part question. Is there a place you can go to kind of vet these vendors and resources? And there's not a central place that rates them on their privacy and security standards or the friendliness of their terms of their business associate agreement. What I can suggest, we've seen security issues get publicized in the last year or so with these different vendors. There are a couple ones in particular that if you search, they've had some known security issues, even with what they call quote unquote HIPAA compliant version of their platform. I hate to call out any vendor in particular, but there are one or two that I know several large healthcare organizations don't allow in their organization because of some of the publicized security issues with those particular vendors. With electronic medical records, if it is a high-tech certified product or platform, they are supposed to have minimum security standards in order to meet that certification. That doesn't mean that there is no platform that is 100% secure. And I think that's important to maybe educate your patients on. While nearly all vendors have some security issues or security risks that have been publicized, that your organization takes privacy and security very seriously. You've worked with your vendor to address that issue and to make sure it has been corrected. Whatever was in the newsletter or publication that the patient saw. That's one of the things in some of these telehealth platforms. We saw the issue come out in February or March, the key security issue, and then the vendors rapidly trying to address that and publish with very specific IT details how they address those issues, and providers and patients can have some confidence with them moving forward. So if you choose a vendor that has had some known issues, I think being equipped with how they've addressed those, if the patient has any concerns or reservations, could be helpful. And being prepared to talk to the patient about what their concerns are and how you're addressing those can be helpful. But unfortunately, there's not a central location that ranks or vets all of these vendors on different security measures.
The Telehealth Technology Assessment Center does have some vetting on their website. However, they can't recommend because we're federally funded. But if you just Google Telehealth Technology Assessment Center, TTAC, you will find some information on platforms that might assist you in that endeavor. So be that as it may not, you know, they don't assess each and every one of them, but the big ones they do.
And Janine, that one kind of vendor vetting step that we were doing when I was serving as the privacy officer, we would ask a question of our vendors, big and small. Have you done a security risk assessment within, you know, a particular amount of time? And if the answer was yes, could they give us either a copy or could they kind of give us a summary of that? And those that were willing to provide a copy or provide information about their most security risk assessment, that was a positive sign to us that they were aware of their HIPAA obligations, they were acting on those. And then some vendors were like, huh, what? No. And that was a red flag to us that while they were calling themselves HIPAA compliant, they weren't meeting kind of a really core foundational piece of the security requirements of HIPAA.
That's exactly right. And we found that at conferences that, you know, they would have these big exhibition centers and that type of thing. And people were really jumping into telehealth and, you know, making money, the entrepreneurs, but they really didn't understand security and HIPAA and that type of thing. So you got to be aware of the ones that maybe are just kind of like the pop-up overnight type providers that may entice you because of their price or, you know, entice you of things that they really can't deliver. So it is important to vet it. It really is. So yeah, thank you for that question.
Yeah, and while there may not be OCR civil monetary penalties, if there's, you still will have to notify your patients if there's a breach, and the PR implications of that could totally destroy confidence in the telemedicine system that you've worked to build. So that's
absolutely
sort of a secondary financial penalty without a formal one.
Very nice. Thank you, Evelyn, for putting that telehealth TTAC link into the chat. If you want to take a look at that, there's the link. Any other questions in the chat that you saw, CC, or does anybody want to raise their hand and ask a question?
I'm looking back through things. Franz, did you have something?
Yeah, and just out of curiosity, when you were talking about patient privacy and the example of the parents leaving the room, what happens when a patient chooses to or has no other choice but to conduct their telehealth visit in the public? So I can see maybe people that are underserved not having internet access and then going to McDonald's or Hardee's to set up with their laptop to meet with the provider. What is the responsibility of the provider in that situation? Is it just to inform them of HIPAA and then conduct the visit, or do they?
Yeah, I think it would always be a good idea if, you know, are you comfortable proceeding with a visit or, you know, having some of these conversations? And if it works its way into more sensitive topics in the course of that visit, is now a good time, or do we need to schedule a different time when, you know, you can be in a different location? From a HIPAA perspective, if the patient is choosing that environment, it's the same as if they chose to bring you know, 10 family members and their neighbor and into a visit. So, you know, in that sense, they're in control. Now, there are settings where that may not be appropriate. If the telehealth session is a group therapy session, that probably is not going to work because you've got other patients who are involved in participating in that session who probably want more privacy than what that patient being at McDonald's or in the library could offer. So there are settings where it may not be appropriate, but if the patient's choosing to do it that way in a one-on-one session, you know, using your professional judgment and discretion in how you're conducting the visit to be as respectful and discreet as possible, it is fine.
I might comment, Richelle, that makes a lot of sense. I have heard a couple of our patients talk about more being in their car in the library parking lot and connecting from there. Again, like you said, that works for some things and not others. It does remind me, we have a fair share, try to connect by driving, and you know, of course, that one is one we don't. we have to say we gotta catch you when you're in a safe place.
Absolutely.
Thank you guys very much.
All right. Looking and seeing if there's any other questions. Well, it is 9:55. I want to thank Richelle very much for her expertise and her time. So thank you very much. Wonderful presentation. And I just want to remind everyone that we are taking suggestions in the chat. If you haven't had the opportunity to type that in, your suggestions for upcoming telemedicine echo topics, we'd love for you to do that. And 2 weeks from today will be our November telemedicine echo. So mark it on your calendar for 9 a.m. and that didactic topic will be determined, and we will send that information out as soon as we get that taken care of. So thank you today for joining us. Stay warm, stay healthy, be well, and we'll see you in 2 weeks. Thank you, guys.